when we say hospital at home in the market, we are talking about true acute style care in a patient's home.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management at the Naveen Jindal School of Management. Here at the University of Texas at Dallas, we bring together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare ecosystem. I'm Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management. Be sure to subscribe on Apple Podcasts, Spotify, or your favorite podcasting app to ensure you don't miss any of the future episodes. You can also join us online at businessofhealthcarepodcast.com. Today, we're going to discuss people, data, and technology to improve patient care within a new innovative delivery model, acute hospital care at home. I'm glad to welcome Tina Burbine, VP of Care Innovation at HealthLink Advisors. Tina is also the host of Let's Talk Data podcast. We have a lot to discover today, so let's get our audience up to speed with hospital at home. Is that the right terminology, Tina?
Yes, and thank you so much, Bob. I appreciate being here. I just want to mention before we dive into hospital at home, I'm a big fan of your podcast, and I especially loved the episode that was recently done about the impact and positive support that concierge surgical processes have to improving patient outcomes. And actually, I think that's a great segue into some of the things that were shared in that episode into our discussion today around hospital at home. And yes, that is now a new standard industry term, if you can believe it. When I think about hospital at home, I always start from the perspective of, gosh, this has been a standard of care globally for many years now outside of the US. And thanks to some regulatory changes, a silver lining of the pandemic, as I say, we now have reimbursement opportunities available through CMS that make this a financially feasible way to provide care to patients. And I think the most exciting part is that with CMS paving the way for us back in 2020, recognizing the impact that this type of care has for patients and being willing to consider, doing this for the long run, meaning well beyond the pandemic, that our payers are now coming to the table and recognizing the benefit of this type of care as well. And so health systems have more of an opportunity than ever before to really build out a new care delivery pathway that is also going to add to their contribution margin as well, in forming new partnerships with not only CMS but also their commercial payers as well.
Tina, this is an interesting topic we're covering today, and with our students, quite often we have a lot of different acronyms. And CMS, tell me again what CMS is for their benefit.
Yes, absolutely. So CMS is the Centers for Medicare and Medicaid Services.
I always thought it should be CMMS, but it's just CMS, it covers all those words there. And then also we hear a lot about EHRs, electronic health records, then we confuse that with ED. And ED is the famous place where you go when you break your leg.
That's right, the emergency room. That's absolutely right.
ER or ED, either way. Yeah. Either way of those, okay. And then, as we provide services to people, we have things called SLAs, service level agreements. Is that right?
That is absolutely correct. And, we always say in any kind of formal partnership arrangement, there is a portion of that contract agreement that stipulates the time within a service being provided needs to happen, where organization A will deliver for organization B. And so when we talk about SLAs within the context of hospital at home, we're referring to the timeframes that any agreements are reached for, say, an ancillary service provider, like a vendor providing oxygen, may deliver to a patient in their home within a certain amount of time frame, whether that's within 3 hours, 2 hours, whatever that need is.
I always like to get that oxygen before the tank is empty. Yeah. So that's a good expectation there. Within Medicare, they have different ways to report the level of services that take place. There are CPT codes, which I don't know what those are, and there's DRGs. What are those? How are those used?
DRGs that stands for a diagnosis related group. And it has to do with how a hospital classifies what type of treatment a patient is receiving, essentially, and the cost associated with that.
It's a good way to bundle the price to a service.
Absolutely, that's right.
Okay, well, thank you for that. It's good. Well, the term hospital at home, that sounds intriguing. Today, we're studying what's going on with hospitals. The rural hospitals in trouble. We just had a session not long ago on that. Other dimensions of hospitals financially, a lot of the hospitals, it's predicted that maybe 10% or so will be shuttered here in the next 5 to 10 years. That capital model doesn't work too well. So when you stop and think about the name hospital at home, I think of a hospital as having everything that you might need to deliver patient care. And to me, that seems contradictory to try to imagine that being at home. So kind of pull back the curtain, if you would, and let us know what type of care is this actually?
Yeah, that's a great place to start. I'm going to begin with the requirements that CMS published when they also announced that a reimbursement dollars were available for this type of care. And that is that when we say hospital at home in the market, we are talking about true acute style care in a patient's home. So in order for a health system to receive the reimbursement money for this type of clinical support, a patient first has to meet an inpatient criteria. So that's somebody who has come into the ED and who fits a certain inclusion criteria, but is also deemed safe enough with the appropriate support in their care plan and the different things that they would receive traditionally in an inpatient bed being delivered to them in a home. There are also other models that teams are beginning to work with as well, such as SNF at home. So there's a wide variety of care at home models that health systems can now be in the position to provide. But the first and the most popular is the true hospital at home, which is providing inpatient level of care in a person's home. And as a patient, I mean, gosh, what a great way to feel like your care team is, encouraging enough, and they've got, they understand what your needs are and they can provide it to you in your own space. For those of us that have been a patient previously at some point in our lives, it's definitely hard to sleep when you're in a hospital environment. And so this just provides so many benefits to the patient and the health system as well.
So I think you've defined acute care as opposed to chronic care. So just for the benefit of our audience, what's the rigorous definition that would define acute care?
So every hospital facility has a defined set of criteria that a patient has to meet for an inpatient bed admission. And it's that same type of criteria that we are using to help support the hospital at home programs as well. So all of the processes that we have for recognizing what a patient's needs are and for understanding, okay, do they actually need an inpatient bed? That same decision process is being made to identify and validate that somebody is going to qualify for a hospital at home care plan as well.
Okay, that makes sense. And the SNF you talked about, that's the skilled nursing facility, right?
Yes, thank you very much. Absolutely. Now, I'm going to add to this conversation that even though the way that we are referring to hospital at home today is representative of the CMS program criteria, which is acute style care, a true inpatient services to a patient, as health systems also continue expanding their value-based care risk contracts, that if they have patients who have ongoing chronic disease management needs, that there is an opportunity to incorporate those patients into your care at home plans as well. So it's an extension of the services that you're providing to patients that help them merge, their virtual care experiences with any in-person visits they may be having with their care teams across the health system.
Okay, because in my thinking, it's fairly limited on this subject, of course, but my thinking was that a chronic situation would be easier to maintain at home instead of something which might be acute. I'm trying to visualize the environment of a hospital, beds, resources, technology, all those things actually being in somebody's home. Does that technology transition take place in that environment too?
It does. There are a few things actually that happen for a team to feel prepared, like like they can support this type of thing. So there are, starting with, determining what condition types and patient criteria make sense for any particular facility. Those things are really going to help define the clinical protocols that a team outlines for their hospital at home program. And I will tell you, some of the advice that we share with the teams we work with is that in order for a first hospital at home pilot to be successful, it needs to be very focused. So while CMS will tell you there's no limit to the DRG code treatments that can be provided in the home, so the reimbursement opportunities are no different than if somebody's in an inpatient bed, it's also important to know that a team is learning how to provide this type of care. It's all new, right? To be able to, as a clinician, either connect with somebody virtually while they're in their home, or also to have some clinical team members, maybe a field paramedic, in the home while they're virtually connected with their clinical staff who are sitting elsewhere. And so in order to understand what that's going to feel like, and to safely support patients in that environment, it's really important to start out with a focused set of criteria that are going to help drive a pilot so that our clinicians can become comfortable with how this works as well.
Okay. So how does this get started in the world that we live? Does it take a healthcare system to decide that we want to offer healthcare at home, hospital at home, or is it done by startup companies? Where's the traction taking place? Is it different levels or at one specific higher level?
I feel like the whole world is jumping into this market right now, Bob. So let me start with our health systems, of course. What's interesting is that when CMS announced in November of 2020 that there were reimbursement dollars available for health systems who were willing to provide care in the home, CMS also at the time announced, hey, here's how you actually obtain approval with our support to do just that. So they actually created a waiver application that allows a facility to go online and start the conversation with CMS and confirm that there are certain requirements that hospital is going to meet in order to support moving patients, care into the home. And so that is step one of being initially approved for this type of care. Now, from that approval, there are a lot of planning steps that are really important to making sure that a program is holistically safe and able to support a higher volume of patients as a health system grows this kind of care delivery pathway. Part of that includes, because you mentioned technology, figuring out, what are the right partnerships that we should be thinking about that are going to enable us to deliver this kind of care. So there are a lot of different options for that. First and foremost, because our health systems have invested so much in their EHRs and the technology and tools that they already have, we always suggest, hey, let's start looking at, which type of EHR are you using? All of the top popular ones across the US do offer a set of workflows to support hospital at home currently. So let's get those into your environment and configured to support your teams. Those workflows are actually configured based on an inpatient bed setting, because our friends at the EHR companies are, of course, also tracking with CMS and understanding what kind of requirements a team has to meet, both from a clinical documentation perspective, and then also what kind of treatments are going to be provided. So they were also very proactive in trying to create very quickly some workflows to support our teams in providing this type of care.
I would think continuity of care would be one of the key elements. So if I had a family member that was in a healthcare system, a major hospital, and they're going to move to a long-term acute care center, I'd feel a whole lot better knowing that that electronic health record existed in both locations. And I'd even feel a whole lot better if that hospital at home had the same type of record, because that way things wouldn't get lost and you'd have knowledge shared. Is that type of system, is that what they're working on today to make that continuity of care become a reality?
Absolutely. So that care plan that's used, whether it's inside the four walls of a hospital or outside, meaning post-acute space with a physician, a specialist, a skilled nursing facility, or in a patient's home, we want the same data there, just like you mentioned, for any care team member to make sure that they are holistically supporting that patient and aware, of any other support they may be receiving from other areas across the health system or even community resources, right? That's an important factor as well.
Okay.
And so, yes, it is absolutely information that is maintained and shared within the EHR. Now, as I say that, because this is a newer offering, not only in the market, but also for a lot of the technology companies that are working, even our EHRs, there's a lot of maturity opportunities here for the workflows that exist. And so one of the things that teams need to identify is, okay, here are the workflows from the EHR that we may leverage, but what are some of the gaps that we need to fill so that we are absolutely supporting exactly what you just described, a full care plan for continuity of care. And for hospital at home, one of the key gaps that exists right now is how to automate your supply chain for hospital at home. So when you mentioned earlier, Bob, what it must be like and how complex it is to think about all of the types of things that somebody gets from an inpatient hospital room, like a bed and meals delivered and regular vital sign monitoring and check-ins from nurses multiple times a day and all of the different communication from the caregivers on a hospital floor, we have to replicate that in a home. And so one of the first things that a team needs to quickly decide is, are the ancillary vendors that you're currently working with by facility able to help deliver and meet whatever SLAs that a hospital at home program provides to deliver that same type of equipment in the patient's home? I always get a lot of questions about pharmacy workflows, for instance, right? Because something that seems so straightforward can become quite complex when you think about moving it from a hospital out into a patient's home. And that is, how are we ensuring they're getting their medications delivered and taken at the right time? Because oftentimes that's being delivered and provided to them multiple times per day. And then incorporating that with whatever med reconciliation that has to happen. And so we know that, our inpatient hospitals always have a pharmacy embedded into the floors, and that is how we're supporting our patients in an inpatient bed setting. And so can we take that same pharmacy team and some of those processes and make them work to fit delivery in the home? Are we going to have pickup done by a field paramedic who will do the delivery, or will we use a courier service? So, and those types of options that teams need to be thinking about really, I think, highlight the opportunities for resource sharing. Our health systems have invested so much to create this experience in an inpatient bed setting. There are opportunities to pull from those same types of teams to support that experience in the home as well.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
I'd like to think that there's a motivation here for a health system to move in this new innovative direction. And I'm not sure what those motivations are, but I'd like to think that the quality of care, the patient experience might be at the top of that list. That would be a big differentiation here in terms of getting well quicker, sooner. At the same time, they got to be following the money. This has got to be a lucrative opportunity and a huge investment, I would imagine. I assume, Tina, that you consult with these organizations to try to give them a model, a financial model that lets them understand the cost and the growth and all that's required in order to have a successful and profitable care at home model.
We do. We provide, the strategy, what plan is going to make sense, because obviously every health system serves a different community, and we don't want to lose sight of patients and what their needs are. So there's a very standard framework that can be used to establish a program. However, it does need to be customized to fit the needs of the community that a health system is serving in, so that it is successful for the patients that will be enrolled in it. When I think about what you just mentioned about, care moving into the home and the trend of this, there are some really fascinating statistics that have been published. And it starts with, McKinsey came out with an article that shared that there's a forecasted $265 billion anticipated to move care into the home by 2025.
Wow.
2025. That's right around the corner.
That's next.
And so, right. And we've seen this huge change with our friends in the payer side of the industry, our insurance companies. I don't know if our students are focused on the dynamic about what the payers are doing, but it's really important to take note of the fact that all of them are making large investments into moving into the care at home space. Humana acquired a traditional home health agency about a year and a half ago. United just set an acquisition record by acquiring a home health agency about 3 weeks ago to the tune of about $5 billion.
Yeah.
So they see the value in providing this type of care, and they are making some chess moves to be able to allow them to also provide this type of in-home care to their members as well. And this is where it gets confusing for patients. And I talk about my dad a lot. He happens to be on a Medicare Advantage plan. And what's interesting is that from one of the larger payers in our market, he gets almost weekly emails offering to do wellness checks and different types of things in his living room. And, that sounds really great, but it's also important for our patients to understand the difference between the care they're getting from maybe a payer who's offering that versus the physicians that you have an existing relationship with in the health system that you typically receive care from.
Yeah, that value-based approach. We had a podcast with Dr. Gordon Chin of Chin Med, and they have a panel of like 400 patients per doctor. The doctor gives out his cell phone number and talks to all those patients every day, really reinforces the value-based approach. We see organizations like Optum moving big into these areas. You mentioned some other large organizations. Is this really driving the value-based care initiative and population health initiative?
I think that's absolutely a part of it. I think there are other factors too, though. And that is that as a country as a whole, we've made some pretty big strides forward, being willing to accept integrating different things like virtual visits through telehealth and different things during the pandemic. And that I call it working at pandemic speed. Teams were very quickly, faster than they've ever done, executing to put tools in the hands of their care teams that they had not previously had. So in that example of telehealth, teams were able to stand up a complete telehealth program in 5 days, because there was that need behind the bed capacity issues and the strain of the impact from COVID during all of our surges in the past 2 years.
Yes.
And so I think that also accelerated the adoption of the use of integrating more technology into the care that we're receiving. Patients were willing to accept it. Clinicians were learning how to do that at a very rapid pace as well. And then we have all this growth in technology in general happening that's expanding our capabilities with technology to deliver care. And so it's all of those things combined that I think have propelled us forward into being more accepting and more willing to pursue standing up these care at home models and to really think about long-term, doing higher levels of acuity of care in the home and being able to do it for a wider group of patients as well.
Yes, I think COVID has opened our minds in a lot of different innovative ways, way beyond healthcare even. We've seen this ability to accept new ways of doing things and understanding things. Cultural differences, the hospital versus the home. I'm trying to look at what I'd really like to get is to have you paint a picture of a day in the life of a hospital at home patient. If you kind of paint the level of scenes that they might experience and how culturally, I keep thinking that hospital at home, you're going to go into a gated community. It's a very nice house with ample access and good utilities and air conditioning and all that, versus maybe which might be the third floor of a high rise somewhere in an urban area. Where does this fit in? Does it fit in today in one place and somewhere else in the future?
Yeah, I think it's a combination of things. I think, depending on the types of patients that a care team is serving, it's going to vary. It works well in a rural environment, just like it works well in an inner city environment. So the opportunities to deliver care in the home, I think, are very wide. And, to talk about a day in the life of, there are so many unique things for patients that we can do in their home that are very realistic for today. So, for example, I often refer to Mr. Baker as our example patient here. But if Mr. Baker presents in the ED today, oftentimes he might share that he lives alone. Maybe he's walking with a cane. He's having trouble breathing. Where maybe we recognize that he's had some frequent visits to the ED over the last 4 to 5 months. And so, as a system develops a hospital at home program, let's create a network of support around him that's going to prevent him from returning to our hospitals, but also being able to stay healthier longer and to be more proactive about maybe it's a COPD flare-up that brought him in that day.
Okay.
And so as a care team evaluates, hey, it is safe to send him home, and here are the things we're immediately doing to make sure that he is stable and that he has the tools to do that as we relocate him back home. We're setting up, immediate virtual monitoring 24/7 for him. We've got maybe there's some education around an inhaler plus some steroids that he's provided immediately. We're doing the appropriate screenings for things like depression. Is there food insecurity, so that if we're sending him home, we can make sure that we can also provide nutritious meal delivery if that's something that's required also, and we can do that, same day. Let's get out the mobile paramedics if we're concerned and we need to do a mobile in-home AFib test if that's going to help. If he's not on oxygen and that's something that's deemed as required, we're also turning that around just as quickly within a few hours to help not only deliver that, but get it set up and educate him about how that's going to work. In our vital sign, in our virtual monitoring, we're not just worried about standard vitals. We're worried about O2 and telemetry, and we're talking with him both over chat and through video, so that we're actually seeing him several times a day. We're actually sending out care team members to his home multiple times a day as well. And all of that information is being compiled in one care plan, so that this virtual net, I call it, of clinicians that are formed around him are there to meet his needs. He can reach out to talk with a nurse on a moment's notice, real time. In addition to having, that physician interaction daily, sometimes multiple times per day, if it's needed as well. When I describe it that way, it's really intended to be no different than the type of interaction and ongoing care you would receive if you were in an inpatient setting. But
it sounds better. It sounds better. That sounds like utopia. That sounds like, wow, it's everything I need here. Now, will CMS cover all of this? Is all part of Medicare?
That is all everything I just described is part of a traditional hospital at home program that, yes, is absolutely part of the CMS approach to providing reimbursement for this type of care. So yes, absolutely.
Okay. Well, I have a question regarding CMS because they've had a number of innovation programs that they've tried. Some have made it to the finish line, some have failed. This particular program looks like it's been pretty successful. And I think COVID probably helped that along. Do you think this will be a sustainable program with CMS? Do they see it as being measured with great value now?
Yeah, it's interesting. It always comes back to the data, Bob, right? So yeah. when I talk about that, what's interesting is CMS is no different. Of course, for the systems that are approved in providing this care, there are ongoing metrics that are reported on a monthly basis. And a lot of the metrics that are being monitored are things like, is there a patient escalation? In other words, once they're admitted to hospital at home, is there ever a need? And what's the frequency to have them transition back if escalated care is needed, right? So, what are the condition types that a team is treating? And of course, what are the outcomes associated with the patients who are enrolled in and cared for in this way? And so health systems are very closely also monitoring all of those types of data. And while CMS initially released the waiver and the reimbursement options for a finite period of time, there is a bill being discussed right now that would actually extend it for far beyond, our pandemic situation. And I will say that I am confident that I think based on the adoption of this type of care, the investment that not only our health system teams have made, but the investment we're seeing to mature the technology, the tool sets, unique things to integrate technology with this type of care in the home, and the prediction that we will continue, on this path as patients are continuing to ask to be cared for in their homes, that the trajectory and our regulatory rules will continue to support that as well.
So if you're a inpatient at a hospital today, and you're interested in this new program, you really like this hospital at home program, where would you inquire? The attending physician, would you ask that doctor, hey, do you guys offer a hospital at home program? Would a doctor know about that? How do you know where to go? And who are your partners out there that go, yeah, we offer that here. You should look into that, or we'll look into it for you. How does this get off the ground if you're an inpatient?
I always joke that so many of our patients are very well-informed individuals these days. It's a consumer-driven market, and who doesn't want that Amazon feel, right, for their own care and well-being, or to help a family member in this way too. So yes, if you happen to walk into an ED or you're having an experience that finds you in an inpatient bed setting of some kind, yes, absolutely ask about it. Anybody working in an inpatient setting will be aware if that's an option for each patient individually. I will tell you that, a lot of teams are putting a lot of effort from a marketing perspective inside their health system to also educate about this being an option in many instances, and are putting a lot of effort into highlighting patients who have had this kind of treatment, who have received it, and what their experience has been. A lot of health systems are now starting to promote short videos to explain what this is to patients and ask if they're interested. So oftentimes, proactively, if somebody enters the ED to a health system that offers this type of care, they will be asked if they're interested based on whether or not their clinical team feels that they meet the criteria safely.
It'd be great if there's some type of simulation out there where you can kind of envision what this would be like, and that could be communicated. Today's world, we seem like we're all trying to transition into this virtual world. You've got Facebook, now Meta, trying to create a virtual environment for us to live in. We laugh at that, but, it may have some applicability. But I can certainly see where we get people educated and get them aware of how to take advantage of some of these different technologies. And, at the same time, if you're the CEO of a hospital, I don't know if the model is keep the beds filled, get more beds filled. That would take on a whole new version of finance to think about, no, let's get these people out into a hospital at home. As long as they have resources that support that, I guess would still work well for them, I guess, right?
It does. And, you mentioned earlier, Bob, that it's so important that any team that's evaluating kind of new care delivery pathway, like hospital at home, SNF at home, whatever it may be, you need to do some very focused and intentional analysis to develop a financial model that's going to help the team understand what are all of your operating costs, what are all the vendor partnership costs that you have in there, and account for the type of reimbursement models that a team is going to pursue so that you understand at which point in time there's a break-even point and then some profitability for the health system as well. So while we always focus on the care and treatment of the patients, because that's first and foremost, our health systems are businesses too, and they need to be making smart decisions about the things they invest in for future clinical care also.
Well, Tina, this has been a very exciting discussion. I look forward to having you back on the Business of Healthcare podcast again. This is a topic that's going to create a lot of interest. And I'm really glad that you've got your podcast out there. Let's Talk Data. I just like the sound of it. Maybe I'm a little bit too nerdy, but I like the concept of the things that you're reaching around and dealing with population health and some of the other, critical areas of change and innovation that's taking place. So it's been a delight to have you on our podcast today.
Thank you so much for having me. And yes, it's always about the data, Bob. So hopefully we can continue the discussion. I would love to follow up and talk more about the metaverse and the impact it has on healthcare. There's a lot of really exciting things that are very realistic and happening in the U.S. today for that. So
there sure is. Time. I like that show. Show me the money. Show me the money. And here it's show me the data.
Show me the data. That's right.
Thank you, Tina.
Thank you so much.
Thanks for listening to the Business of Healthcare podcast. To learn more about the Center for Healthcare Leadership and Management, go to jindal.utdallas.edu/healthcare.